Hello, everyone. Good afternoon. Welcome to today's webinar. My name is Allison Hilkaya. I'm with the Washington State Department of Health. And today's webinar continues our commitment to support healthcare providers across the state in your efforts to discuss COVID-19 vaccination with your patients. This webinar is sponsored by the Power of Providers Initiative, which is our effort to elevate the voices of medical professionals as trusted sources of healthcare information in your communities. And we're happy to be able to offer our members these peer-to-peer knowledge sharing opportunities. If you've missed any of our previous recordings, fortunately, they're linked on our website, so you can still go view them and catch up there. The website is doh.wa.gov/pop. And if you're watching today, but you're not already a member of the Power of Providers, you can join. Any healthcare professional can be part of the initiative. You don't have to be licensed to administer a vaccine in order to share our life-saving mission. You can do that just by having conversations with your patients about how they can protect themselves and their communities from COVID-19. So you can visit doh.wa.gov/join-pop to learn more and join us today. I'd like to mention that this session is being recorded, as the other webinars have been, and we will add closed captioning for better accessibility, and then that video will be posted on the Power of Providers webpage. Also, the slides for today's presentation will be emailed out to all the registered participants. So with no further ado, I'd like to introduce today's presenter, Dr. Eric Chow. He is the Chief of Communicable Disease Epidemiology and Immunization for Public Health, Seattle and King County. And he's also an MD and a clinical assistant professor at the University of Washington in the Division of Allergy and Infectious Diseases and in the Department of Epidemiology. He has a very extensive resume, and I'm only going to highlight a few of his accomplishments for you. He supported Public Health Seattle King County's response to the original long-term care facility COVID-19 outbreak and helped characterize the initial cases of multi-system inflammatory syndrome in children in the United States. He is recognized as a top expert on respiratory virus epidemiology, and we're delighted to be able to host this platform for him to share his knowledge with you today. Take it away, Dr. Chow.
Well, good afternoon, everyone. Thank you so much for that really kind introduction, and really appreciate the invitation to present again today. Today's topic on respiratory viral activity was really born out of my interest in understanding the effects of the COVID-19 pandemic on community respiratory viral infections. And I'm hoping that in today's presentation, I'll be able to summarize some of those findings for you and the implications, particularly as we move forward and think about a comprehensive respiratory viral approach, that one that might be inclusive of an endemic SARS-CoV-2. So we have a number of slides to get through, and I'd love to save time for questions. So let's go ahead and continue and move forward. Let's see here. All right, I have no disclosures to report. So my lifelong dream, as all of you know, is to have all of you become respiratory viral subspecialists at some point, and to inspire you and to share with you why this topic is so interesting. We'll start off by giving you a little bit of background on what respiratory viral infections are, and to really highlight why we care so much about these infections. We'll start off by characterizing the clinical burden of respiratory viral infections. I'll give you a little bit of background on some of the pre-pandemic epidemiology of some of the most common respiratory viruses in our community, including influenza, RSV, and rhinovirus. And then we're going to use that knowledge to be able to understand some of the trends and changes since the start of the pandemic through the various phases, and how that parallels the changes in mitigation efforts, human behavior, and such that led up to the recent surges in the most recent respiratory viral season that started at the beginning of the fall. And then I'd like to leave you with some food for thought, particularly as conversations trend towards what is our overall strategy going to be with regards to respiratory viruses in general, as well as how do we incorporate an endemic SARS-CoV-2 into that conversation. So let's go ahead and jump into the next slide. So Let's start off with this really basic question. What are respiratory viral infections? Now, I by no means intend on insulting anyone's intelligence who is on this call. Whether you're a clinician or non-clinician, everyone probably has some form of firsthand experience with respiratory viral infections. But even for those people who are most seasoned with clinical care involving these types of diseases, I think you're going to get different answers depending on who you ask. So I think this first few set of slides is meant to be a primer to make sure that we're all on the same page, that we're all talking about the same thing. And this year, I think there was a lot of attention on the tridemic of 2022, and this brought about renewed attention regarding common respiratory viruses. And infections such as influenza and respiratory syncytial virus, or RSV, has up until this year has been long forgotten, mostly because during the pandemic, a lot of the infections involving these two viral pathogens has largely decreased. But this year was an important reminder that these remain an important public health threat to our community, particularly to our healthcare system. So again, the tridemic was a reference to the increase in the early increase in respiratory syncytial virus surge, particularly among pediatric cases, and then followed by an increase in the number of cases of influenza. Of course, the third virus here is the constant threat of SARS-CoV-2, which has continued to cause ongoing burden of disease in our community. But I also want to remind you that even though we talked about the tridemic of viruses, there are a lot of other viruses out there that make up that viral milieu in our community. And so even though we concentrate a lot of our discussions on influenza, RSV, and SARS-CoV-2, there are other viruses that float out there. And sometimes we're not always able to test for them, mostly because testing is expensive and we don't always have antiviral treatments that would change our management. But just to know that there are a lot of other respiratory viruses that contribute to the burden of infection. So again, what makes it respiratory? What are the defining characteristics of a respiratory virus? And I think to be able to understand this, we'll have to review a little bit of our anatomy. So as you're all aware, the respiratory system is aligned with respiratory epithelial tract cells that go from the nasal cavity all the way down to the alveoli. And like other viruses, respiratory viruses lack their own machinery to be able to replicate. So they actually hijack and depend a lot on our host machinery to actually produce new viral particles that then go on to infect other people. So they trick these cells into thinking that it is food or other type of nutrients, and they get endocytosed into the body of the cell. The virus then does its magic, replicates, and then destroys the cell, and then moves on to other hosts before the immune system is able to neutralize them. And transmission for respiratory viruses are predominantly through respiratory droplets or aerosols. Different viruses use different sized particles to be able to get from one person to the next. As you're aware, this is a spectrum of size. Aerosols tend to be smaller particles that get suspended in the air, and they stay suspended in the air for some time. And other viruses tend to be a little bit more hardy, and they can actually survive on surfaces, and hence they're able to transmit by fomites and direct contact. In fact, some of them are so hardy that despite our best efforts to be able to clean surfaces, they're able to survive for long periods of time, enabling them to continue to transmit long after the person has left the building. Another reminder is that once you get an infection, you then go on to develop disease. And from a clinical perspective, we oftentimes, for the respiratory tract disease, we oftentimes divide this up into two anatomical parts. We think about this from the standpoint of the upper respiratory tract as well as the lower respiratory tract. This cutoff I find is somewhat sometimes arbitrary, and I always constantly have to remind myself where exactly that cutoff is. But for the purpose of today's presentation, I think it's just important to know the general kind of idea behind this. So when we refer to upper respiratory tract infections, we're often referring to things like common cold and sore throat. Lower respiratory tract infections are typically what we include things like pneumonia, bronchiolitis, acute bronchitis, and exacerbations of underlying respiratory disease, including asthma and chronic obstructive pulmonary disease, or COPD. And as much as we like viruses, and as much as this presentation is about viruses, it's important to recognize that respiratory disease is not just limited to viruses. This can also include bacteria, fungi, and parasites. But by far the most common, of course, are viruses, and this is why we're having this conversation today. And again, we talk about respiratory viruses in the context of respiratory disease, but this is an important reminder that, based on what we've learned from other respiratory viruses, influenza, SARS-CoV-2, that respiratory viruses can also cause extrapulmonary manifestations, as highlighted by some of the literature that's been published. From an influenza perspective, it's been well characterized that there's an association between influenza infection and acute cardiovascular events, which includes myocardial infarction. And all of you are well aware that there are certainly extrapulmonary manifestations of SARS-CoV-2. We briefly talked about these in prior presentations. You're going to hear wonderful presentations from other speakers in a few weeks, but this includes MIS-C as well as post-COVID-19 conditions. Certainly includes respiratory conditions as well as non-respiratory conditions. And I leave you these literature links so that you can read at your own leisure. But of course, this talk today is about respiratory viral circulation. I did cover briefly some of the viral properties. We talked about transmission routes, but the reality is that there are a number of different factors that play into respiratory viral circulation. People oftentimes ask us in public health to predict what the next season is going to look like. That's virtually impossible. It is very difficult, even for those viruses who we have, for which we have a lot of data from year in, year out. We see patterns change over time in unpredictable ways. So it's very difficult. It's just like asking us to predict what the weather is going to be like a year from now. That's going to be really challenging. Even when you're in the midst of a surge, it is very difficult to predict what it's going to be like from moment to moment because of all these factors. But we're hoping that with time, we'll learn more about these factors and be able to model out what the transmission routes might look like. So the next few slides are to highlight why we care so much about respiratory viruses. So I'm going to attempt to summarize some of the literature around respiratory disease burden. So I'll start off with this article, which I think I chose this mostly because they have beautiful figures and it really highlights a point that I'm trying to make here. So in this article, we'll start off by characterizing some of the causes of fever in outpatient Tanzanian children. It is not often that we actually have data at this level, so this hence why it was able to be published in a high impact journal. But take a look at that bar chart. This really highlights an important point that I'm trying to drive home here, is that in this cohort of children, they were able to identify the acute respiratory infections was by far the most common cause of fever in outpatient children. And then when you actually took a deeper look into the causes of acute respiratory infections, vast majority of them were actually respiratory viruses. And this, again, highlights that respiratory viral infections cause a substantial burden of the acute respiratory infections out there. Now, like I said, it would be really great if we were to actually precisely highlight the actual number of infections that are caused by, that lead to the numbers of upper respiratory tract infections that are out there. That's not an easy task, mostly because in order to be able to do so, you have to have access to data, you have to have good clinical care, you have to have documentation, then you have to have people who are able to report it. So as you can imagine, there's probably disproportionate ability based on the country you're from, resources that you have to be able to do so. So in order for us to be able to even characterize this, you have to do some modeling to be able to assess what that might be. So this group ambitiously undertook this task and estimated that in 2019, way before the pandemic, that for upper respiratory tract infections alone, there were more than 17 billion incident cases of them. And this is, again, before the pandemic. This is probably far higher now with COVID-19 floating around, circulating in the community. And just as an aside, we know that, again, from the literature I just shared with you, that the vast majority of upper respiratory infections are likely caused by viruses. We know that viruses don't get treated by antibiotics, but many people do get treated for upper respiratory infections with antibiotics. So as an aside, this leads to a lot of big discussions about antimicrobial resistance and inappropriate treatment practices that just contribute to other issues that we won't have time to cover in today's talk. And then what about lower respiratory tract infections? So this group tried to do a similar thing of measuring the global burden of lower respiratory tract infection in 2016. And they actually found that it was the leading cause of death in people of all ages in 2016. This, again, way before the pandemic. This number is probably quite a bit larger now with COVID-19 causing so much mortality around the globe. They estimated that there were about 2.1 to 2.5 million deaths that year alone, which is stark stark reminder that, again, respiratory disease is an important thing to study, and it is likely that a large number of these cases are caused by respiratory viral infections. So, of course, this talk today is specifically about respiratory viruses, and to be able to differentiate respiratory disease by pathogen, you have to have the ability to be able to test. And as you can imagine, there are many parts in the world where testing is just simply not available, nor is it necessarily needed for clinical diagnosis and treatment. So oftentimes there are large gaps in the data for us to be able to accurately portray what that total burden is. But a colleague of mine back at CDC, Danielle Juliano, put together this really complex modeling study to really put a number to the number of influenza-associated respiratory deaths. And they found in their study that each year there's between 291,000 to 645,000 deaths attributed to influenza-associated respiratory deaths alone. But as we know, influenza causes more than respiratory deaths, so this number likely underestimates the total burden of mortality associated with influenza infections. And similarly, along a similar vein, RSV, folks try to characterize the global burden. Most of the infections occur in young children. So in this study, they estimated that RSV prior to the pandemic caused approximately 33.1 million episodes of lower respiratory tract infections, leading to 3.2 million hospital admissions and about 59,000 in-hospital deaths in children younger than 5 years. And we know, obviously, this is not a full characterization of all the burden caused by RSV, because this is really only for children younger than 5 years old. Now, we wouldn't be able to fully characterize circulation if we didn't understand surveillance. So I wanted to take a few moments to describe what respiratory viral surveillance is and within the context of influenza, which is probably has the most robust surveillance systems out there. So for those people who have previously studied epidemiology or who are in public health themselves, you'll probably be well versed in the fact that surveillance is in fact the backbone of public health communicable disease work. It helps us establish a baseline burden of disease and tells us when abnormal happens. So, for influenza, we know that even though we have seasonal surges, we oftentimes think about influenza during the context of the influenza season, but the reality is that influenza continues to circulate at baseline rates, and then surges usually during the fall to winter. Surveillance systems can come in many different flavors. This can include community-based sites, healthcare settings. They can include death data, syndromic, and virologic reporting, which we'll see in just a bit. It's incredibly helpful for the purposes of pandemic preparedness to identify when an abnormal circulation pattern might be occurring, suggesting that we should be preparing for broader surges. This does also help contribute to our knowledge of respiratory viral epidemiology, and also it's important to acknowledge that despite our best efforts to have a complete surveillance system, limitations do exist, mostly due to testing availability, testing practices, as well as health-seeking behavior by individuals. Holidays is a good example where when clinics close or people choose not to go into the clinic to get tested, this can certainly impact reporting as well. So starting at the broadest sense, at a global scale, influenza is tracked through a global surveillance system hosted by the WHO. As you can imagine, there are certain limitations with this. Again, these data are likely dominated by countries that do have access to testing, access to reporting, access to the ability to collect all this data and then report it to the WHO. And then also many of these countries that have that ability are often located in the Northern Hemisphere. So, there's a certain bias to that. But I still think that this is worthwhile to look at this data to just get a general sense of what's circulating around the globe. CDC also does a wonderful job. They put together the CDC Weekly Flu View report. So for those people who haven't already included this as part of their weekly reading, I find this incredibly helpful to just get an idea, a picture of what's going on nationally around influenza activity. And this provides you a quick snapshot of that. And this is where they summarize all the surveillance reporting that they collect into a succinct report. And I find it helpful. Pulling from that weekly flu view, view, the CDC does report on influenza surveillance through testing and virologic practices. So over here on the left, we see influenza positive tests reported by US clinical laboratories. Here on the right, it's influenza positive tests from US public health laboratories, giving a slightly different cut of the data. On the right, you'll see the colors indicating the different subtypes of influenza that have been reported by US public health laboratories, which again gives you a sense for whether there are shifting changes in the types of influenza that's predominating. Influenza surveillance is also inclusive of syndromic surveillance. So as in this graph here, they report out on the number of outpatient visits attributed to influenza-like illness. So influenza-like illness, of course, includes fever, cough, and/or sore throat, which is, of course, not specific to influenza and could be caused by other viruses. So I bring your attention to the green graph that highlights the 2019-2020 season, where you'll see a peak around week 50, 52 that highlights the surge of influenza before the emergence of COVID-19. And then later on in the season, you see a couple additional spikes, likely attributable to the other viruses are circulating, as well as the emergence of COVID-19 here in the United States. Influenza surveillance is also includes hospitalization surveillance. I find this helpful, particularly as a measure of severity. Again, it's a proxy measure of severity because you would imagine that only severe cases would be hospitalized so this actually captures some of that information. So this compares the influenza hospitalization rates every year. So this is actually just the cumulative rate, and then there's also another cut that I'll show in a bit that shows the weekly rates, which I find helpful. Influenza surveillance also includes mortality surveillance. So through the National Center of Health Statistics, the CDC reports out the number of cases of pneumonia, influenza, and COVID-19 associated mortality. And this is reflected in the graph on the left. And then another important one, a sobering one that highlights, that despite our best efforts to improve vaccination across all age groups, we still see a lot of influenza-associated pediatric deaths. I do find this helpful to highlight again to parents in the community why it's so important to vaccinate people of all ages, including children, with the annual influenza vaccine. And so we'll talk a little bit about this in terms of the changes that you're seeing right there in the middle, and then the resurgence of influenza-associated pediatric deaths in the 2022-2023 season. We talked a lot about the national surveillance systems. We also have a similar system here at the state and local levels. Over here on the left, you'll see the Washington State Department of Health report out of influenza testing here in the state. And then here on the right, we have our Public Health Seattle-Kane County data. Again, you'll get a sense for what the general influenza activity is nationally by looking at CDC's website, but I do often turn to state and local levels because sometimes we see a little bit different circulation patterns based on different testing practices, activity, and just general human behavior. So it's good to look at all these different levels. And of course, just to highlight that even within the hospital systems, you can see surveillance systems established. So University of Washington also does a public report out of their respiratory viral testing as highlighted here in this on this slide. Just to bring your attention, many of you who are on the call are probably already familiar with the Seattle flu study, but this was a collaborative effort by folks within Seattle and Kane County to put together a surveillance system in advance of a pandemic to better understand what the circulation of respiratory viruses is looking like. And believe it or not, they actually set this up right in 2019, thinking that this would be a useful tool as a proof of concept moving forward to be able to detect respiratory viruses moving forward. And believe it or not, they were able to capture some of the initial cases of SARS-CoV-2 here in Kane County to alert the rest of the nation that in fact SARS-CoV-2 was circulated within the community before other people had caught on. And this is a graph that reflects all those dynamic changes. And we'll take a deeper dive into this in just a bit. But first, a few slides on just the general epidemiology. So to be able to understand trends, I think it's important to review over some of the epidemiology of some of the viruses that we're talking about, starting with SARS-CoV-2. So as you're aware, SARS-CoV-2 is short for the severe acute respiratory syndrome coronavirus 2, which is an enveloped positive sense single-stranded RNA. And one common thread between all these viruses is that you'll see that most of these that I'm going to be talking about today are RNA viruses. So when you think back on your biology, RNA viruses don't generally have the proofreading ability that other DNA viruses do have. So they're able to mutate quite a bit. In fact, they mutate so much that actually the vast majority of viruses, viral particles are produced, end up not being as fit as the original virus that infected you. But because they're able to replicate so much, they produce so many different mutations that certainly at least one of them are able to then transmit to the next person, carry on the genome, and then also pass along any additional fit mutations, leading to, as in that we are well aware of, emergence of SARS-CoV-2 variants. So just to keep in mind that piece of viral property that contributes to their ability to transmit from person to person. SARS-CoV-2 is one of 7 coronaviruses that infect humans, and there are, in addition to SARS-CoV-2, there are other 4 species that are called the common cold coronaviruses that commonly circulate in our communities. Of course, SARS-CoV-2 has ongoing circulation in the community. Fortunately for us, we have highly effective vaccines that is certainly central to all public health efforts to mitigate the burden of disease. But the sad reality is that despite our best efforts to promote all these preventative measures, SARS-CoV-2 continues to cause ongoing substantial morbidity and mortality, as highlighted by the Johns Hopkins COVID-19 dashboard, which I find helpful for reference for numbers. What about influenza viruses? Well, influenza viruses are segmented envelope negative sense single-stranded RNA viruses, of which there are 4 types that circulate in the community pre-pandemic, 2 subtypes from influenza A viruses, including H1N1 PDM09 and AH3N2, which is the predominant subtype this season. Influenza B prior to the pandemic actually had 2 lineages that's co-circulated, B Yamagata and B Victoria. And we'll talk a little bit about how one of these may no longer exist anymore. These co-circulate and cause seasonal epidemics, again, in temperate regions. In tropical regions, their circulation patterns look a little bit different. Also, we talk a lot about influenza A and B, but the reality is that we also have influenza C that commonly circulates in the community, frequently causing mostly upper respiratory tract infections, common cold type symptoms. So less is known, less has been invested in understanding the circulation patterns of influenza C. Most of the conversations are dominated by A and B. And then going back to your viral lectures, when you're studying, when you're studying in school, influenza can have drifts and shifts. Drifts are what leads to required updates for the influenza vaccine. These are small changes that require the annual update, annual influenza vaccine update. And then we have periodically we'll see antigenic shifts. And this has led to previous influenza pandemics, including the one that occurred in 2009. Just as a reminder for influenza, medical countermeasures, we have both a vaccine as well as antivirals that are used to prevent and treat individuals, which is an important thing to keep in mind as we move forward discussing about public health interventions. And then a word on respiratory syncytial viruses. So RSV are envelope negative sense single-stranded RNA viruses, of which there are 2 subtypes, RSV-A and RSV-B. These cause seasonal peaks that sometimes overlap with influenza, as in this most recent season. They interestingly differ a little bit in their circulation patterns from influenza in tropical areas, where you'll see seasonal peaks in tropical areas as well, predominantly in colder months. Now, we oftentimes talk about RSV in the context of childhood infections, but the reality is that elder family members are also at risk. So this wonderful paper highlights some of the most common causes of community-acquired pneumonia in children. And of course, we all know this, that young children are particularly at risk for RSV infection. But the reality is the same study looking at looking at adults, the common causes of community-acquired pneumonia. You'll see here that the fifth most common cause in this study was RSV. And so this is an important piece to not forget that, in fact, our older community members are at risk for RSV pneumonia. Unfortunately for RSV right now, there are limited pharmaceuticals to be able to prevent RSV infections. Right now we have palivizumab, which is a monoclonal antibody used in the prevention of RSV in high-risk infants. However, I am excited to say that there are other treatments and vaccines that are currently being vetted and discussed and potentially could be approved for use in the community as soon as this upcoming respiratory viral season. So this will be another important factor that plays into our strategy moving forward. All right, so let's talk a little bit about rhinoviruses. Now, as opposed to what we saw with SARS-CoV-2 and influenza RSV, rhinoviruses are non-enveloped single-stranded positive sense RNA viruses. They are closely related to enteroviruses. So when you actually see testing done in the hospital using multiplex, oftentimes you see it referred to as rhino/enteroviruses. That's because just at that level, you wouldn't be able to distinguish between the two. But rhinoviruses specifically include 3 species that cover 180 types of viruses. So it's an incredible amount of diversity, probably hence why it's so easy for you to continuously get rhinovirus infections. You're probably getting infection from different types of rhinoviruses. It's often thought that rhinoviruses have year-round circulation, which is certainly reflected when you look at rhinoviruses as a whole. But if you were actually to do genomic sequencing on all these rhinoviruses and were able to get down to the type level, some people have postulated that it's actually not a year-round circulation. You're actually seeing individual surges of types throughout the year. So, hopefully we'll be able to get additional funding and such to be able to better characterize that. But that was an interesting hypothesis that was posed by some of the articles that were published on rhinovirus during the pandemic. Oftentimes rhinoviruses are associated with a common cold, and maybe in many cases they are, but it's also important to recognize that rhinovirus can cause the exacerbation of chronic respiratory diseases. So as in the case of asthma, rhinoviruses have also been implicated as healthcare associated infections. They also cause exacerbation of cystic fibrosis, and is a very common cause of febrile illness and pregnancy. So this is just to say that rhinovirus is very much more than just a cold. All right, so now to get into the meat of the presentation. So I want to bring your attention back to the Seattle flu study dashboard, because I think that this really does illustrate the point that we're trying to make today, which is that there were substantial changes to many of the respiratory viral circulation during the pandemic. So at the top, you'll see the list of viruses detected from the start of the Seattle flu study in 2019 through to 2023. And below, I pulled out SARS-CoV-2 just to highlight when SARS-CoV-2 was surging and how that relates to the other circulation of other respiratory viruses. As a reminder, this red bar I put in indicates the first case of SARS-CoV-2 detected here in the United States, right here in Washington State on January 20, 2020. We didn't see many changes to the respiratory viral circulation until later on, when the WHO declared the COVID-19 as a pandemic on March 11th. And then, of course, following up shortly after that, Washington State implemented its stay-at-home ordinance on March 23rd, 2020. That was part of a package of a number of mitigation efforts that the community utilized that really brought the other respiratory viruses to a halt. So what are these mitigation efforts? Well, this included a package of non-pharmaceutical interventions, and these are oftentimes used at the start of the pandemic, before the widespread availability of effective medical countermeasures such as vaccines or antivirals. And as you remember, for the vast majority of the first part of the year, we really didn't have we didn't have vaccines and we didn't have great antivirals at that point. So we really did rely on these efforts that individuals and communities took to be able to slow the spread of infection and decrease the burden of disease, and hence decrease the burden that was put on our healthcare system that was severely strained. This slide is to acknowledge that non-pharmaceutical interventions, we oftentimes think of that as masking and hand hygiene, but really they can occur at various different levels. This includes individual, community, environmental, governmental, which includes things like travel restrictions and entry by non-citizens, number of other things that to be able to fully characterize all the processes that fall under the category of NPIs or non-pharmaceutical interventions. You'll have to really dig in there to find them. But a number of different interventions were employed, was utilized during the pandemic to really slow the spread of SARS-CoV-2. So as a result of all these mitigation efforts, you'll start to see a lot of change, and we'll go by virus here. So starting with influenza, you'll see that influenza virus that in the 2019-2020 year had a peak right before the start of right before the emergence of SARS-CoV-2. And it was maybe on a downward trend, but as soon as SARS-CoV-2 came about and mitigation efforts were put in place, numbers drastically dropped and actually remained low, very low, historically low, until 2022 came about, when, as you're aware, there was already a lot of pandemic fatigue early in the year, and people were starting to resume some of the activities that they did pre-pandemic, and this has led to an early surge that we saw locally in April through July, and then into the tridemic period that we talked about briefly. So this slide is to highlight again that in 2020 and 2022, before that surge in April, we saw some of the lowest rates, cumulative rates of laboratory confirmed influenza hospitalizations here in the influenza-associated hospitalization surveillance data. And then we also see over here, during the period in which a lot of mitigation efforts were still in place, influenza-associated pediatric deaths were historically low. But sadly, of course, we see the return of a lot of these infections as people lightened up on their use of mitigation efforts. We also saw this decrease in influenza globally, as highlighted during the period of 2020 and 2021 in this graph. What about RSV? Well, RSV behaves slightly differently. So initially we saw a decrease at the start of April associated with the stay-at-home ordinance. But as children returned to school, as childcare resumed, we saw a little bit of a jump. We saw an interseasonal a surge starting in July and April of 2021 going into 2022. And of course, don't need to remind anyone here on this call, but of course, we also saw huge surges as a result of the most recent tridemic early in 2020, early in the respiratory season of 2022. I want to bring your attention to this article that was actually just published in Journal of Infectious Diseases a couple weeks ago that I think really highlights an important point of the trends that occurred in RSV during the time of the pandemic. So over here on the left, you'll see the surge patterns every year pre-pandemic. The authors highlight that by far the age group that had the highest numbers of RSV positive tests were those younger than 5. That makes sense. This is what we know about RSV causing bronchiolitis in young children. But it's also important to acknowledge, again, that older adults, those greater than 65, represented here by the green arrows, also were the second most affected by RSV infections. Then we have this period where there are very few infections, and then of course we get to where we are now, a transition from 2021 to 2022, and you see a surge in younger than 5, followed by a slightly change in age patterns, as you see by the green line there. This is a different display of the same data that is used by the authors. In blue, we see the pre-pandemic period, highlighted by this beautiful line that I drew. You'll see that there's initial increase for those in the youngest age groups, and then it slowly tapers off for the middle-aged individuals, and then those who are elderly. You'll see an increase in the number of infections for those 65 years and older. But interestingly, in the pandemic period, which incorporates data up through 2022, you can see that there's, again, that same surge or same increase in number of infections in the younger age groups, but not a corresponding increase in the older age groups. And I'll share some of the thoughts that they had in just a bit, but I just want to review over the trends that were being seen during the times of the pandemic. So let's move over to rhinovirus. So rhinovirus actually behaved very differently from many of the other respiratory viruses out there. And there were a lot of questions posed as to why this might be. So rhinovirus initially decreased, as depicted by these arrows, along with the full scope of mitigation efforts. So when everyone was staying at home, no one was traveling, everyone was using a mask, everyone was doing hand hygiene, we actually saw a decrease in the number of rhinovirus infections, as shown here between April through July. But as soon as anything lessened up, as soon as people decided that there were a number of things that probably changed between July and October of that year, but you quickly see that rhinovirus cases came roaring back to levels from the pre-pandemic period. This was also highlighted by findings in this MMWR that was posted, showing initial decrease again, but a quick turnaround and a return to normal numbers of infections, even within the first year of the pandemic. So why did we see all these differing circulation patterns between viruses? Are there viral properties that may have contributed to these findings? Well, one hypothesis that was posed was maybe it's something about the viral envelope that actually made influenza or RSV less fit and maybe rhinovirus a little bit more fit. So it's thought that maybe this envelope made it more amenable to cleaning, or it made it viral envelopes made it less fit and less prone to what am I trying to say here? Is that the viral envelope, the lack of a viral envelope actually made rhinovirus a little bit harder on surfaces and able to transmit beyond that initial period that someone was in a space. And so hence why some people postulate that this is why rhinovirus is able to survive on surfaces. So, which is an interesting thing to note. But I think the other things to also know about rhinovirus that makes it hardier and makes the other properties about rhinovirus that also make it have a greater fitness to be able to transmit to other people is the fact that it does have so many types, and it also has prolonged shedding that allows it to transmit to other people for longer periods of time. And what about some of the factors that influence RSV circulation that you saw in the graphs I showed earlier? Well, one hypothesis that people had is that the differences in changes in age groups that we saw was attributed to mitigation efforts used by those who are 65 years and older. So in the pre-pandemic period, when we saw that the two most common age groups to be affected by RSV were those younger than 5 and greater than 65. Now, with the opening of schools and childcare again, we see the same infections occurring in that age group, as highlighted by this spike in 2021 and 2022, but we don't see the same corresponding increase in those 65 years and older. And it's hypothesized that those 65 years and older continue to use masking and continue to isolate, quarantine, or socially distance from other people, hence why we didn't see the same corresponding increase in RSV infections in older adults. Other factors that may be at play here are includes viral competition interference, which is actually a very interesting process. Several articles have highlighted ecologically that there seems to be community changes that occur when there are two predominant viruses that are occurring in the community at the same time. So in this graph, the authors state that there's evidence of viral interference because you only see surges in influenza when rhinovirus cases are down, and then vice versa. And they hypothesized that the reason for this type of viral interference is that when you have an infection with one virus, it actually induces a broad, non-specific antiviral immune host response that after getting infected with one, you are less likely to get infection with another type of virus. Viral particles also induce or cause cells to reduce or downregulate their receptors, preventing subsequent viral entry into cells. And also when an individual is infected with two different viruses at the same time, one virus generally outcompetes the other. So there is an interesting kind of mechanism that is thought to maybe contribute to the circulation patterns of respiratory viruses, but one that requires further investigation, I think, to be able to definitively prove to see as a factor that factors into a community circulation of viruses. So what are the lessons that we learned from some of the circulation trends and patterns that we saw during the pandemic? Well, one thing is that envelope viruses, including influenza RSV, actually experienced dramatic decreases associated with both SARS-CoV-2 community circulation and PI implementation. Non-envelope viruses, such as rhinovirus, were actually more capable of persisting despite NPI measures. So if we really want to reduce the number of rhinovirus infections, we really have to put together a package of different mitigation efforts to bring down infections, just because they're so much hardier, there's so much more diversity, and they can shed for longer periods of time, as highlighted in this last bullet here. So this brings us up to the most recent season. I think this still is worth it's worth a discussion. So again, bringing us back to the slide on the tridemic of 2022 really brought renewed attention to some of the common respiratory viruses and why we need to have a strategy in place that is that encompasses influenza, SARS-CoV-2, RSV, and other respiratory viruses. So we saw here that with the influenza circulation this past fall, had an early surge, actually, in fact, one of the highest that we've seen in the last 10 years. But as soon as it ran its course, it actually decreased quite dramatically, and we're seeing fairly low levels of influenza circulation over the last few weeks. And then similarly, as I mentioned previously, during the pandemic, with all the mitigation efforts in place, the influenza-associated pediatric deaths dramatically decreased. But of course, with the return of influenza infections, unfortunately, we've seen a number of deaths already reported this year. One thing to point out is that I mentioned this earlier, but influenza, we talked about 4 different types of influenza circulating year-round pre-pandemic. But interestingly, I'll just leave this here. Influenza B Yamagata actually is one of the 4 viruses that circulate pre-pandemic. But B Yamagata has not been detected since 2020, and there's a lot of hypotheses that this virus lineage actually has gone extinct, which is interesting and also important because this is still one of the viral components in our annual influenza vaccine. RSV has similarly caused an early surge, as you all recall. However, fortunately, those cases have also decreased since the holidays. So there's been a lot of talks also about endemicity and SARS-CoV-2, and I did want to share a few thoughts that I have as we near the end of our presentation here. So one big question that all of us here in public health have is, how do you fold SARS-CoV-2 into a comprehensive public health strategy for respiratory viruses? For SARS-CoV-2 and influenza, we have vaccines available on the horizon. RSV may also have a vaccine available. So how do we fold all of this together into our approach for the next season? And I think the short of it is that we're still all trying to put our heads together and try and devise a comprehensive strategy. But I think there are a few points around the concept of endemicity that I think should be central to our thought process moving forward. So what is endemicity? A lot of people have asked me about this, particularly with the end of some of the emergency measures that have been in place since the start of the pandemic. Well, endemicity as a concept is not a new term. This is something that that is commonly referenced, particularly to animals and plants. When we think about, for example, here in Washington State, I oftentimes use the example that evergreen trees are endemic to Washington State. That means that they exist naturally, they have ongoing existence in a particular community. The same could apply to viruses. So influenza is an endemic virus that continues to circulate in our community, causing seasonal surges. But to my knowledge, there's no clear epidemiologic definition or even a threshold by which we would say definitively SARS-CoV-2 is now an endemic virus. It's just we're continuing to watch its patterns and its behavior over time before we would necessarily declare it as an endemic virus. To me, I think there's a lot of indications now that SARS-CoV-2 is still very much in a pandemic, causing excess mortality and still has a lot of risk of emergence of novel variants that could cause surges. So watching it very carefully, I think, is still really important. What are some endemic kind of characteristics that I'd be looking out for? Well, for one, I would expect a little bit more predictability. I would like to see more of an established or known baseline. This would require several seasons worth of data before I would suggest that anything was endemic. Will SARS-CoV-2 have a seasonality? Will it have a surge, or will it have year-round circulation? I think a lot of these questions we simply don't have the answer for, but I know that a lot of strategies have moved towards assuming that SARS-CoV-2 would have seasonal surges, much like influenza, but I don't think that is definitively known yet. And then what about novel variants? What role will they play? Now, we saw a lot of chatter about XBB.1.5. There was a lot of concern that it would spread quickly, causing surges in its wake. But I think a lot of people would agree that although we're continuing to watch this very carefully and certainly displacing some of the other existing variants, it hasn't moved as quickly as we had anticipated. And as far as I'm aware, there isn't any convincing data to definitively say that it is more severe than other variants that we have seen. But of course, we're still watching it carefully to see what it will do locally. And then another important point that I think is important take home here is that there is an amount of baseline disease that society has considered to be acceptable when you're saying that something is endemic. That somehow right now, even a lot of people say, oh, it's an endemic disease. Is it really okay that 3,800 people a week in the United States continue to die from SARS-CoV-2? Is that an acceptable baseline? So a lot of these questions I think are important to pose, particularly as we plan out a strategy moving forward. Because we have to remember that when there continues to exist a burden of disease at that level, that we know that throughout the pandemic, that there's been disproportionate impacts in some of our community members, that when compared to white populations, Black and Hispanic populations have had increased rates of SARS-CoV-2 infections and increased risk of hospitalizations. And we know it's likely that they're also disproportionately impacted by things like post-COVID-19 conditions as well. So it's important to acknowledge that when we say things like endemicity, there's a certain societal acceptance of burden of disease that we're willing to accept. And is that truly acceptable? That's an important question for all of us as we think about a comprehensive respiratory viral strategy. And disparities, of course, are likely to exist across respiratory viral infections. So what are our thoughts around the public health strategy for SARS-CoV-2 moving forward? I know we have a few minutes left, so I just want to briefly touch on this. For me, the core part of our approach really should be centered around maximizing the uptake of vaccine. We know that our vaccines are incredibly effective against severe outcomes, particularly among those at highest risk for severe outcomes. But unfortunately, due to fatigue and just a general lackluster response to just like concerns around COVID-19, uptake of the most recent updated bivalent booster has been fairly poor. Moving forward, the FDA has outlined a potential plan for having an annual COVID booster, but I think more data still is needed to be able to understand whether just this one booster is needed or whether for certain groups of people, whether a second booster may be needed to carry them over and protect them against severe disease. Another piece to the whole issue of access is really around the commercialization of vaccination. So as you're all aware, after the federal government moves in the near future, the federal government will likely no longer purchase vaccines, and so it will solely be on the this will be wrapped into insurance coverage. So individuals will then have to be responsible for paying out of pocket any co-pays, or for those people who are underinsured for the full price of the vaccine, which is thought to be somewhere around $100 per vaccine, which is a substantial burden for a lot of people to carry. And then just to end on the fact that, here in Kane County, we've really made an effort to improve access to vaccination. This will be a central core part of our public health strategy moving forward. How can we maximize, improve access to people who otherwise wouldn't be able to get the vaccine? And because of this central tenet of our strategy, our primary series vaccination rate actually was one of the highest in the country at 84%. However, even with these numbers that we celebrate, we still know that there are disparities by region, and we know that in the south part of our Kane County, we could still do additional work to improve rates. Unfortunately, we're just not quite where I would like to see our rates for the updated bivalent booster. Despite our best efforts to improve access and to message the benefits of getting a vaccine, our vaccination rates are still at 31% of people who have received the updated bivalent booster. And again, we're continuing to work on access issues in the south part of the Kane County. And then just a few thoughts to leave you all with. Part of my goal of formulating a COVID-19 and comprehensive respiratory viral response really hinges on expanded collaborations with healthcare partners, community-based organizations, community leaders, and regional health authorities to really get the appropriate message to the people who to people out there to ensure that they have the accurate information to know that boosters and vaccines are still effective against severe outcomes, and we would still recommend uptake of the booster to best protect people from severe disease. We need to enhance and broaden our message across age groups, communities, language, and social media platforms. And we also need to increase access to testing, vaccinations, and treatment to the broader community. Testing remains really important because this helps ensure that people have access to the appropriate antivirals to reduce risk of severe disease. So I want to, the summary slide just reiterates all the points that I just made. I know we just have a few moments left. I want to leave some time for questions, so I'm just going to jump to the end. And then for those people who would like to read our most recent article that was published in Nature Reviews Microbiology, it really does a deep dive into the changes and trends and the effects of the COVID-19 pandemic on community respiratory virus activity. I'll leave this here. Thank you.
Thank you so much, Dr. Chow. That was fantastic. You packed a lot of highly relevant information into a short amount of time. We're really grateful for all those research-based insights into respiratory virus circulation. I think the word unprecedented was overused perhaps at the beginning of the pandemic, but continues to characterize the environment that we're all in today. I don't see any questions in the Q&A box for you. Does anyone have a question? This is sort of last call to be able to drop a question into that box while Dr. Chow is still with us live. And while you're thinking about a question you may want to ask, I'll remind everyone that this webinar has been recorded, and we're going to share out the link with all registered participants once we get the recording closed captioned and up and available. And we'll also email you registration links to the next peer-to-peer learning webinars that we have scheduled. So please take advantage of those and share the invitations with your colleagues in healthcare. And we have a short survey, the link to which is going to go into the chat box and it will be in the follow-up email. We'd very much appreciate your feedback on this webinar, as well as your ideas for future webinar topics. So I see one question for you, Dr. Chow, and that might be all we have time for. The question is, what is the predominant influenza strain this year and vaccine efficacy for the flu?
Yeah, well, thank you so much. So this year we saw influenza A, H3N2 as a predominant influenza subtype circulating. With some of the changes we saw, maybe a slight bump in H1N1 PDM09 after the holidays, but H3N2 remains the predominant subtype. And as I mentioned earlier, influenza B Yamagata has not been detected since early 2020. I think that the early influenza vaccine effectiveness is still being calculated. So I'm still looking for those data. If other people are aware of publication of the influenza vaccine effectiveness data, I would love to hear about that. But to my knowledge, I haven't seen any early publications on that yet.
Okay, thank you very much for responding to that question. Thank you again for the excellent presentation. I'd also like to thank my colleague Scott Pilkington for his work behind the scenes to produce this webinar. And I'd like to thank Secretary of Health, Dr. Umair Shah, for his support of the POP initiative. And I want to thank all of you healthcare professionals who tuned in today for your efforts to serve Washingtonians throughout the pandemic. We're grateful for your partnership. Please join us for our next webinar, and I hope you all have a great weekend.